Okay, this is where we're going to start. Last time we talked about all the neurotransmitters and what they did. Now we're going to talk about all the substances that interact with those neurotransmitters. Alcohol directly affects GABA, methencephalin, and serotonin. We talk about GABA all the time, that it depletes it. But serotonin, it also increases the serotonin level, which makes you feel a little bit better. But then when you're not drinking, you feel a lot worse. So there you go. Benzodiazepines directly affect GABA and glycine. They increase the GABA level. Marijuana affects anandamide, as we said before, arachidonyl glycerol or 2-AG, acetylcholine, and dynorphin. Heroin affects endorphin, enkephalin, and dopamine. LSD, acetylcholine, dopamine, and serotonin. Nicotine, epinephrine, endorphin, and acetylcholine. The uppers, cocaine and amphetamines, affect dopamine, epinephrine, norepinephrine, serotonin, and acetylcholine. MDA and MDMA, ecstasy, especially affects serotonin, but it also affects dopamine, epinephrine, and norepinephrine. PCP affects dopamine, acetylcholine, and alpha and endocytosine. Neurotransmitters attach themselves to receptor cells on the receiving entity, the muscles, the organs, or other neurons that are chemically structured to only accept that neurotransmitter. However, select receptor sites may have different functions for the same neurotransmitter. There are 7 types of serotonin receptors, each of which has a slightly different function. Dopamine has 5 types of receptors, referred to as D1 through D5. It's the D2 receptor site that is used for psychoactive substances. And that's one of the reasons why we talk about the dopamine, the D2 receptor sites. Each neuron maintains and transmits only one type of neurotransmitter, except for neurons that transmit epinephrine, which may also transmit norepinephrine. And for that reason, when they first discovered epinephrine and norepinephrine, they thought they were the same chemical, and because they inhabited the same receptor sites. But now we know that the two are different, that they have different chemical structures. However, a neuron may have receptor sites for any number of neurotransmitters. A neuron is stimulated when it receives enough neurotransmitter to create a chemical imbalance in the neuron that forces sodium and potassium gates to open. The increase of positively charged sodium and potassium ions from outside the neuron and the flooding out of negatively charged chloride ions causes an electrical chain reaction to run down the neuron to the axon terminal. And this is why we call it an electrochemical reaction. At the axon terminal, the electrical stimulation causes the vesicles to release their neurotransmitter into the synaptic cleft, which in turn stimulates a partner neuron. Excitatory neurotransmitters work by opening sodium gates, allowing sodium into the neuron. Inhibitory neurotransmitters work by opening chloride gates, making the neuron more negative and thus more difficult to stimulate. The stimulation of the neuron by the neurotransmitter is known as the first messenger system. If the neuron is stimulated by another entity, such as a biological or chemical change, it is known as a secondary messenger system. The neurotransmitter can't remain in the synaptic cleft, or the reaction won't stop, so it must be removed. This occurs in one of 2 ways. The neurotransmitter is chemically broken down, as in the case with acetylcholine. Acetylcholinesterase is an enzyme that gets into the synaptic cleft, and it breaks down the acetylcholine and it makes it into chemicals that do not affect the neuron. The other way that a neurotransmitter can be discharged or taken out of the synaptic cleft is by what they refer to as reuptake. Reuptake is where it takes it back into the neuron, the vesicles that have released it initially, and that's known as reuptake. The number of receptor sites is not constant. When the amount of neurotransmitter decreases, the cell will increase the number of receptors so that as much neurotransmitter as possible finds a place to attach. And this is known as upregulation. So if you're not feeling very good, if you're feeling a little bit depressed, what your neurons will do, it will increase the number of serotonin receptor sites, and that's known as upregulation. This is the reason why you normally don't feel a lot different from one moment to the next, and that's because of your body is trying to keep this interesting balance. If there's too much neurotransmitter in the synaptic cleft, the number of receptor sites will decrease to prevent overstimulation. And this is known as downregulation. So if you overstimulate let's say you take MDMA. MDMA increases the amount of serotonin in the synaptic cleft. MDMA does that because there can be a toxic level, a toxic number, toxic amount of serotonin in the synaptic cleft. The neuron, in order to protect itself, will reduce the number of receptor sites so that it won't be destroyed. And this is known as downregulation, where it reduces the number of receptor sites. This occurs when someone takes drugs. The individual takes more and more of the drug, trying to achieve the same reaction as they had originally. Because the drug is overstimulating the neuron is downregulating. Therefore, they don't get a toxic level. Excessive use of drugs may cause a permanent downregulation, and of course, this is one of the problems. This is one of the things that happens to you when you take methamphetamines. Not only that, but methamphetamines also destroy brain cells. And because of that, it takes a while for you to recover. And the question is, do you ever get back to the point where you were before? And potentially the answer is no, because you have permanently downregulated those neurotransmitters, or those receptor sites. Psychoactive drugs work because they act as either agonists or antagonists. Agonists either mimic or facilitate the effects of a neurotransmitter. Nicotine works on acetylcholine. Alcohol mimics GABA. LSD mimics serotonin. And THC, of course, anandamide. If this happens partially, it is known as a partial agonist. Antagonists block neurotransmitters. If the receptors stabilize, making it inactive by a drug, the drug is referred to as an inverse agonist. How drugs affect neurotransmitters? They can block the release of the neurotransmitters. Heroin blocks the release of substance P. They can force the release of neurotransmitters, forcing more to be released than is released naturally. Cocaine forces the release of norepinephrine and dopamine. Ecstasy, MDMA, forces the release of serotonin. The drugs can prevent the reabsorption of the neurotransmitter. SSRIs, of course, block the reuptake of serotonin, elevating the person's mood. The drugs can inhibit an enzyme that helps synthesize the neurotransmitter. Blood pressure medicines inhibit enzymes that allow the production or norepinephrine, which would cause high blood pressure if allowed to be released in the synaptic cleft. Drugs can inhibit enzymes that break down neurotransmitters in the synaptic cleft, allowing the neurotransmitter to remain in the cleft. Methamphetamine inhibits monoamine oxidase and catechol-methyltransferase, which break down norepinephrine and epinephrine in the synaptic cleft. The drug can interfere with the storage of the neurotransmitter. The drug can do a combination of any of these interactions and create the situation that people are enjoying or whatever. While some drugs have desired effects like making the individual resist fatigue or block pain, they can also be dangerous. Cocaine forces the release of norepinephrine and dopamine, which makes the individual not only stay up beyond normal exhaustion, but respond in an overly excited and sometimes violent manner. Heroin blocks pain and creates a euphoric sensation by attaching to receptor sites in the reward reinforcement pathway, but unfortunately it also attaches to the breathing center, depressing respiration. Now, if it just made you feel good, if you just had that euphoric effect, that would be one thing, but it also can put you to sleep, and sometimes it can put you to sleep forever. LSD acts as both a stimulatory neurotransmitter, and it also alters the user's perception of external messages, mixing their perceptions so that they may hear images and see sounds. This is known as synesthesia. Other psychedelics block the action of acetylcholine, creating hallucinations. The body may deal with drugs in several ways. It may create tolerance, may create tissue dependence, may create psychological dependence. You may go through withdrawals, or you may break down the drug, which is, of course, known as metabolism. Any foreign substance will be treated as a toxin in the body. The liver and the kidneys will try to eliminate it so that it cannot do any damage. If the individual continues to use the substance, the body will adapt to having the drug present. This adaptation to the presence of a toxin is called tolerance. Tolerance to drugs will force the individual to take more and more of the drug to get the same effect. A methamphetamine user will achieve a certain level of euphoria and energy the first time they use it. If they use every day for 100 days, the 100th day, they will have built up a tolerance for the drug that will necessitate a 20 times increase on the amount they used the first time. As you can see, negative things happen to you. In order for tolerance to occur, sometimes the drugs must be taken irresponsibly. If the individual is taking Valium at higher doses than the doctor prescribes, or the doctor is prescribing heavy usage of the medication, the tolerance will be accelerated. Research shows that there are individuals who have built up a tolerance to the degree that they were using 100 to 200 times the standard dosage. Tolerance will return to normal if the drug is no longer used. Types of tolerance, there are several different types of tolerance. Dispositional tolerance, the body accelerates the metabolism of the drug by producing more of the enzyme used to metabolize the toxic substance. The more people drink alcohol, the greater their tolerance because of dispositional tolerance. Thus, the individual will have to consume higher levels of alcohol to become intoxicated. Pharmacodynamic tolerance, affected nerve cells become less sensitive to the drug. When opioids are used, neurons begin generating fewer receptor cells to the opioid to lessen its effects. The body will also produce cholecystokinin as an antagonist to the drug. Behavioral tolerance, the brain compensates for the effects of the drug by using parts of the brain not affected. A person who is drunk can force themselves to appear sober when necessary. A reverse tolerance, as the drug destroys tissue, the user becomes more sensitive to the drug and can tolerate less and less of the substance. This is what happens to alcoholics who suffer from cirrhosis of the liver. Since the liver doesn't work as well, a little alcohol will get them drunk because the liver is not operational enough to metabolize the alcohol. So as they become more and more, as they drink more and more, of course, and destroy more and more of their liver, it doesn't take as much alcohol to get them drunk. Acute tolerance, tachyphylaxis, the brain and body adapt instantly to the toxic effects of the drugs. Tolerance to tobacco occurs this way. People who try to commit suicide using barbiturates may experience the same instant tolerance and survive twice the lethal dosage. LSD will not work if two doses are taken close together due to tachyphylaxis. Select tolerance. The body develops tolerance to mental and physical effects at different rates. This occurs with opiates and sedatives. With barbiturates, sleep will be induced long after the euphoric effect is no longer present. Inverse tolerance or kindling. The brain chemistry changes so that the person becomes more sensitive to the effects of the drug. With continued use, cocaine and marijuana users will get a minimal effect, and then after months will start to get an intense reaction. In the case of cocaine, it might cause heart attack or stroke. Cross tolerance: if a person develops tolerance for one drug in a family of drugs, they will be tolerant of other drugs in that family. The opioid family is this way. Tolerance to heroin will make the person equally tolerant of morphine, codeine, or methadone. A person tolerant of Xanax will be tolerant to other benzodiazepines and even the depressant alcohol. A person tolerant to barbiturates will be tolerant to benzodiazepines. Tissue dependence: this is a biological change of the body to adapt to the presence of the drug. This usually occurs after prolonged use. Allostasis sometimes will occur where the tissue and the organs of the body depend on the drug to be functional. In these circumstances, cessation of the drug usage will cause dangerous and dramatic withdrawals. In select circumstances, cross-dependence will occur, where dependence of one drug can be alleviated with another drug. Psychological dependence: addiction used to mean that the person taking the drug was tissue dependent on the drug, but with continued research in brain imaging technology, it has been recognized that psychological dependence is an important factor in addictive behavior. The altered states of consciousness that are caused by select drugs can lead to continued misuse to avoid life's problems. It is not acknowledged that psychological dependence occurs before tissue dependence, and that the response rate from either is similar. Psychological factors that induce reinforcement: drug automism. The individual uses the drug aimlessly, unconsciously, and repetitively. Negative reinforcement: unpleasant states encourage drug usage. Smokers will wake up in the middle of the night to smoke to dissipate nicotine withdrawals. Social reinforcement: peer pressure and the need for social inclusion encourages continued use. Opioid effects: causes numbness, euphoria, dryness of mouth, constipation, decreased pulse, low blood pressure, shallow breathing, and inability to cough, pinpoint pupils, and malaise. So if you came in to my emergency room with an opioid overdose, the first thing we would look for is pinpoint pupils to try to determine what your problem was. I mean, if we have no clue what is happening, we can see the tracks in your arm, but we don't know if it's opioids or PC. We don't know what it is. We have no idea. First thing we'll do is we'll look at your pupils to determine. Of course, we would probably take all your vital signs and we would determine, oh my goodness gracious, this person has low blood pressure. We can barely find his pulse or her pulse, whichever the case may be. Then we would look at your pupils to see if they are equal, because there's a possibility that you've had a stroke. So we'd look at your pupils. Withdrawal symptoms from opioid substances: tactile reaction, pain everywhere, just pain. Psychological reaction, where it's euphoria before, when you're taking the drug, now that you're in withdrawals. You have anxiety, depression. You certainly crave the drug. Physical excretory reaction, whereas before you weren't sweating, you had dry mouth. Now you're sweating, you have a runny nose, tearing, increased salivation. Whereas before you were, the opioids cause constipation. Now, of course, you've got diarrhea. Circulatory reaction, now you've got hypertension, whereas before you had low blood pressure. Respiratory reaction, excessive coughing, whereas before you couldn't cough, which is really kind of interesting when you're taking opioids, heroin or whatever. You can't cough. You just can't do it. And if to listen to these people, when you're talking to these people, a lot of times you can hear the phlegm in their throat, but they can't get it out. Optic reaction, dilated pupils; muscular reaction, severe hyperreflexes, and muscle cramps. And a lot of that has to do with the excessive sweating that they're doing. They're losing a lot of water. Drug withdrawal is the body's attempt to rebalance itself after cessation of prolonged use of psychoactive substances. Many times for a chronic user, fear of withdrawal is one of the reasons for continued use. Withdrawal often entails muscle aches, pain, insomnia, vomiting, cramps, and on occasion, convulsions. Convulsions are not that common with most withdrawals, but they are especially common with alcohol withdrawals. Uh, Types of withdrawal, non-purposive withdrawal, visible physical signs due to tissue dependence, seizure, sweating, goosebumps, vomiting, diarrhea, tremors. Purposive withdrawal, expectation of withdrawal symptoms, causing the rationalization of continued use of the psychoactive substance. This is normally what happens with people who are heroin users. The reality is that heroin makes you feel so euphoric that people don't want to get off of it. The withdrawals never kill anybody, not those types of withdrawals. If you want to kill somebody with withdrawals, that's alcohol, but not heroin. Heroin doesn't really do that, but they relapse a lot, and the reason is because it isn't that they fear the withdrawals; it's just that they enjoy the euphoria so much. It You find a lot of musicians who have a difficult time performing, so they'll take heroin. They'll shoot up with heroin, and then they can do it because it makes them feel so good. Then they have a difficult time getting themselves off the heroin, and eventually they overdose and die. But the reason they don't want to go off of it is because of the euphoric effect. Now they become dependent on that effect. They don't think that they can perform unless they're shooting up. And this is the way it tends to work. Protracted withdrawal, heavy craving for the drug, even after the addict has been detoxified. This is usually caused from an external cue that causes the subject to have flashbacks to use and withdrawal symptoms. This often causes a recovering addict to relapse. Post-acute withdrawal symptoms, persistent emotional, physical problems that last for 3 to 6 months after recovery, unclear thinking and cognitive impairment, memory problems, emotional overreaction, sleep disturbances, motor coordination, dizziness problems, difficulty managing stress, and craving the drug. Sometimes drug abuse is a symptom of other underlying problems. When this is the case, the user will sometimes seek the desired effect by experimenting with drug usage. Replacement will replace the desired drug with another intoxicant. Some people, we used to do this with when we were trying to get people who were alcoholics to stop drinking alcohol. We used laudanum. And laudanum, of course, is alcohol mixed with heroin, with opium, I'm sorry. Multiple drug use of different drugs to alleviate different symptoms, cycling, using a drug intensely for a period of time and then abstaining to lower tolerance to allow the body to repair. Cycling is what killed Amy Winehouse. She was an alcoholic. She wasn't getting the same effect from the alcohol, so she decided to abstain for 2 or 3 weeks. Once her tolerance went down, then she went on a binge and she poisoned herself with alcohol. Stacking, using 2 or more similar drugs at the same time to achieve a specific effect. Mixing, using drug combinations to acquire a new effect. Speedballs or cocaine and heroin. That's what killed John Belushi, and that's what killed Chris Farley. Speedballs. Marijuana laced with cocaine. It was speedballs that killed. That's okay. John Belushi and Chris Farley, especially. Marijuana laced with cocaine, ecstasy and LSD, known as X and L, methadone and Klonopin. It mimics heroin. Sequentialing, going from one addiction to the other. This can either refer to drug sequentialing, drug replaced by a compulsive behavior, or one compulsive behavior replacing another. Morphing, using one drug to counteract another. Cocaine user drinking alcohol to come down. Using coffee to come down off of a drunk. Using methamphetamine to function during a heroin high. The level of use is determined by the amount that you use, the frequency that you use it, the length of time psychoactive substances have been used, and the impact the drug usage has on the user's life. Categories of usage include abstinence, experimentation, social recreational use, habituation, abuse, and addiction. Many individuals cannot choose their level of drug use, but are at the mercy of the psychoactive properties of the drug being used. Abstinence means that an individual does not use any psychoactive substances except accidentally, even if the person has a strong hereditary or environmental susceptibility for compulsive drug use. By never starting, they never get hooked. These individuals might display other compulsive behaviors, gambling, overeating, compulsive internet use, excessive sexual behavior, and of course, these individuals try to stay away from it because they've seen it in their own lives with their own relatives. Research shows that the individuals who wait until they are 18 years or older to experiment with alcohol, nicotine, or marijuana are less likely to use these substances as gateway drugs for more dangerous substances such as cocaine or heroin. However, if the individual experiments between the ages of 10 and 12, they're more likely to use the early experimentation as a gateway to more serious usage. Individuals who don't start smoking until the age of 21 are very unlikely to develop an addiction to nicotine. Anyone who doesn't try an addictive substance until age 21 will probably not become addicted. Experimentation with psychoactive substances occurs because of curiosity, but no pattern of usage is developed and there are no negative consequences such as the experimentation unless usage leads to injury, accident, or illness. The individual has an exaggerated reaction. A pre-existing physical or mental condition is exacerbated. The user is pregnant. The individual is arrested for use. Heredity or environment dictates addiction. Previous addiction with other substances leads to relapse. Social recreational use. Social recreational users may seek out a drug for the effect, but no permanent pattern of use is developed. Usage can be controlled by these individuals as long as they do not develop drug-seeking behavior. Habituation, the individual has developed a pattern of usage, but there has been no negative effects on the individual's life. This is referred to as habituation because, though there is no increase of usage, the usage pattern indicates that there is a definite craving for the substance. Abuse, the individual continues to use the substance despite the negative life consequences that have occurred. These consequences can be personal, such as in relationships, problems in their social lives, financial problems, legal problems, continued use despite arrest for possession, medical problems, personal health. If you're an alcoholic with diabetes, that's kind of really dumb. Heavy smoker with emphysema, and I've seen this, people with emphysema who are on oxygen, they have to go off the oxygen to smoke their cigarette, but they're so addicted to tobacco that they can't, that they'll go outside and they'll pull their cannula out of their nose in order so that they can smoke. Oxygen is highly inflammatory, so not inflammatory. It's highly flammable, I'm sorry. The cocaine user with hypertension, work or school related, emotional stability, LSD users with mental instability, probably not the best idea to use LSD. Addiction, the difference between abuse and addiction is the compulsive behavior of the addict. Addiction is a classification if the individual has no control over duration of usage or the amount used. The individual has been unsuccessful at control. They spend an inordinate amount of time obtaining drugs or recovering from usage. They limit social, occupational, or recreational activities for use. They continue use despite physical, social, relationship, or psychological problems. They use in the morning for a jump start on the day. They defend their drug usage with anger or even rage. They experience withdrawal when unable to use the drug. They must increase the amount used to obtain the desired effects. Addiction comprises the 4 C's: loss of control, compulsive use of the drug, craving the drugs, and continued use of the drugs. The American Psychiatric Association has identified substance use as a mental illness since the printing of their first diagnostic and statistical manual of mental disorders in 1952. The current DSM-5 divides substance abuse disorders into 2 general categories: substance-related disorders and substance addictive disorders. The DSM-5 deals with several drugs, which include alcohol, stimulants, cannabis, which is another name for marijuana, cocaine, hallucinogens, inhalants, opioids, anxiolytics, anxiety-causing drugs, sedatives. Anxiolytics work on anxieties. Sedatives, hypnotics, caffeine, tobacco. The addictive disease model. This model of addiction sees addiction from the medical point of view. That addiction is a disease. It's chronic, it's progressive, it's relapsing, it's incurable, it's potentially fatal, and that's the disease model. This model assumes that the addiction is caused from genetic irregularities in brain chemistry and anatomy that are triggered by certain drugs. Research shows that heredity influences drug use and addiction as much as 40 to 60%. Alcoholics Anonymous uses the disease model. Compulsive drug use with prolonged intoxication with the need to continue use. This is the disease model again. Inability to control use. Inability to stop use despite physical, mental, or social problems. Repeated attempts to control use. Increase intake over time. It's incurable, it's pathological. Reactions such as blackouts or dramatic personality changes. The behavioral environmental model. This theory purports that negative environmental factors such as abuse, anger, and peer pressure may cause people to seek, use, and sustain a dependence on substances. This model emphasizes the progressive nature of 6 levels of drug use: abstinence, of course, experimentation, social recreational use, habituation, abuse, and addiction. And that's where we got the list that we had before. The academic model. Addiction occurs when the body adapts to the toxic effects of drugs at the biochemical and cellular levels. Natural balance has been thrown off, causing 4 physiological changes: tolerance, tissue dependence, withdrawal syndrome, and psychological dependence. The diathesis stress model. This model was first developed to explain the causes of schizophrenia. It is a combination of the addictive disease model and the behavioral environmental model. Diathesis means a predisposition or vulnerability to, and in this case, the individual may have a genetic and environmental disposition to drug addiction. Stress triggers the drug need, and the stronger the diathesis, the more likely the individual will drift into addiction. Heredity. Researchers have found that genetics does influence addiction, but that there are over 100 genes that have something to do with drug abuse. There are receptors, receptors on the neurons, gene transcription factors, enzymes, neuropeptides, G proteins, and transporters, and all of these have to do with addiction. And we're talking about a lot of different drugs too. We're talking about from alcohol all the way to LSD. Of course, we'll be talking about all these drugs, but each one, of course, affects a different type of neuron. It affects a different neurotransmitter. Looking at twin studies, Goodwin found that of identical twins separated at birth were most likely to choose addiction or abstinence patterns of their biological parents over their adoptive parents. Similar research found that 61% of the sample maintained nicotine dependence similar to their biological parents, and 55% displayed the same alcohol dependence of their parents. Researchers looking at males in treatment found that children with one alcoholic parent had a 34% greater probability of being an alcoholic than the male children of a non-alcoholic. When both parents were alcoholics, the child had a 400% probability of being an alcoholic. If both parents and a grandfather were alcoholics, the individual had a 900% greater probability of being an alcoholic. One of the things to remember that 28 million Americans have one parent, at least one parent who is an alcoholic. 28 million people. Researchers have found that 70% of severe alcoholics have a dopamine control gene called DRD2A1. Among social drinkers, only 30% have the gene. When this gene is present, the individual has fewer dopamine receptor sites in the nucleus accumbens. Since many of the missing sites are D2 sites, the individual will need more intense stimulation to feel satisfaction. DRD2A1 gene seems to indicate the tendency for any problem behavior, as it has been found in other addictive behaviors other than alcoholism, gambling, ADHD, aberrant sexual behavior, overeating, antisocial personality disorder, and Tourette's syndrome. Some refer to this gene as the compulsivity gene and the process as the reward deficiency syndrome. People with DRD2A1 tend to consume large quantities of psychoactive substances before becoming intoxicated and then have greater dysfunction when they do get drunk, such as blackouts and brownouts. There are also genes that make it less likely that a person will develop an addiction. DRD4 gives the individual an excess of dopamine, which has been shown to play a role in spiritual acceptance, making it less likely that the individual will accept the addictive lifestyle. Environment, interactions with the environment, but especially the home environment, make new nerve cell connections and alter the neurochemistry that the individual was born with, determining if and how the individual will use psychoactive drugs. Factors in the environment: physical, sexual, emotional abuse, stress, love, poverty, living conditions, family relationships, nutritional balance, healthcare, neighborhood safety, school quality, peer pressure, the internet, television. All of these are environmental factors. The environment molds the brain's architecture and neurochemistry, determining how the individual will react to outside influences. This is especially true in the first 10 years of life. The brain develops from the front to the back, meaning that the adolescents are more prone to more impulse control behaviors like substance abuse. Recent research shows that it takes at least 20 years for the brain to become hardwired, and the prefrontal lobe continues to grow until around the 44th year, which means that mine stopped growing about 30 years ago. About 30 years. Let's say 26 years ago. And memories are established through a network of neurons involving select neurotransmitters, norepinephrine, serotonin, acetylcholine, and dopamine. The more an action is repeated, the more likely the individual will remember it, unless the memory is emotionally intense, in which case the memory has a stronger memory network. Hence the intrusive memories of a traumatic event that may end up causing post-traumatic stress disorder. That's because it was such an intense emotional situation. Okay, so you got a situation where two people are interacting, two romantic people in a romantic situation. One individual rejects the other. For the individual who has been rejected, this is a far more intense emotional situation for that individual than it is for the other individual. Okay, so let's fast forward 25 years. The two people meet again, and the one that had the intense emotional reaction to the breakup, this individual may potentially still be angry, and so they slap the other person's face, and the other person's going, "I didn't even know that. I'd forgotten that we were dating." That kind of a situation. So one of them has carried the torch, as it were, whether it's a torch of anger or whatever. One's carried the torch and the other has forgotten it completely. Children growing up in a chaotic environment where there is excessive emotional pain can deal with the pain in several different ways. And I want you to think about this. A lot of times we'll see this happen in families. So you've got 5 or 6 kids in the family, and they will all handle the chaotic environment in a different way. They can face the pain and try to deal with it. They can find people to help them deal with it. They can accept what happened. They can run away. They can become hyperactive. They can become angry and fight. They can make jokes. They can develop an addictive use, such as drugs, food, gambling, and sex. Now, if we think about this, if we've got 6 different kids in the family, we've got one that handled it really well and they became successful in their life. They have another one that every time a stressful situation comes up, they run away. We have another one that has been hyperactive all their lives. They were diagnosed with ADHD. It's not really ADHD, it is a chaotic home environment. You got another one that is in prison because they have anger issues and they get in fights all the time. You've got another kid in the family that is the joker, and the last kid in the family, of course, becomes the addict. Uh, if the stress continues over time, the counterbalancing behavior may become ingrained in the brain and becomes part of the individual's personality. In the future, when an unwanted emotion arises, they will draw to the simplest solution, the counterbalancing behavior. And of course, if they get into it, so all these people marry the right person or the wrong person, it really doesn't matter. They get into a bad situation. The one person will handle it. The person that ran away will run away from this situation. Maybe get divorced over and over and over again because that is the way they handle bad situations. The hyperactive person will become hyperactive. The angry person will potentially fight. Try to fight in their situation. One person will make jokes, and the last person will take drugs. The people most likely to abuse drugs, stress is common in the home. Abuse of some kind occurs in the home. Drugs or drinking are commonly used in the home and among the individual's peers. Healthy ways of reacting to stress and or anger aren't learned. Society tells the individual that psychoactive substances are normal and an acceptable way to solve life's problems. Living in a community where access to legal and illegal drugs are easy. There are pre-existing mental conditions exacerbated by the negative home environment. Healthy brain chemistry can't be maintained because of poor nutrition. The media inundates the individual with advertisements supporting the use of select psychoactive substances. One belongs to a peer group where excessive use of psychoactive substances is normal. Psychoactive drugs, heredity, and the environment may prime an individual for addictive behavior, but it is the psychoactive substance that they decide to use that will determine the impact the addiction will have on their life. Excessive drug use will not only make the individual more susceptible to more and more use, but more vulnerable to other stronger drugs. Select psychoactive substances, particularly methamphetamine, cause the death of brain cells through a process known as apoptosis, where damaged cells are programmed to kill themselves. And this is what happens to somebody when they take methamphetamines. So if they take methamphetamines over a 3 or 4 month period, when they stop, they have all of these damaged and destroyed cells, neurons in their brain. So it's going to take about 18 months for their brain to repair itself. And they get what they refer to as meth head. In other words, they have memory problems, they have anger issues, they have a lot of different problems. They won't be as intelligent as they were before they started taking the methamphetamines. Nicotine produces an immediate and long-term change in the levels of dopamine and norepinephrine, which leads to a faster development of tolerance and dependence. Some drugs have a greater power to positively reinforce and therefore compel to a continued use. Cocaine and heroin are this way. Compulsive behavior, Compulsive obsessive behavior mimics drug use, which in turn causes the brain to be rewired. Gambling, eating, shopping, sexual activity, video games, internet use, all of these are compulsive and obsessive behaviors. Research with video games usage has shown that dopamine is released in the reward reinforcement pathway when an individual plays video games, an amount equivalent to methamphetamine usage. Compulsive behavior, PET scans of compulsive eaters has demonstrated that there is a decreased number of dopamine receptor sites, especially the D2 receptor sites in their nucleus accumbens. Research shows that between 25 to 63% of compulsive gamblers have been dependent on alcohol or other drugs in their lives. It has been demonstrated that gambling creates brain disruption similar to drug or alcohol usage. The drug that pushes the individual the hardest and quickest into addiction is smoking, nicotine, and tobacco. It's number one. Tobacco is number one. It's the nicotine in tobacco. The drug that pushes the individual the second hardest and quickest into addiction is smoking crack cocaine. Smoking. Inhaling it. The drug that pushes the individual the third hardest and quickest into addiction is smoking or injecting heroin. The drug that pushes the individual the fourth hardest and quickest into addiction is injecting methamphetamines. The drug that pushes the individual the fifth hardest and quickest into addiction is snorting cocaine. The drug that pushes the individual the sixth hardest and quickest into addiction is ingesting opioid painkillers. The drug that pushes the individual the seventh hardest and quickest into addiction is ingesting any amphetamine. The drug that pushes the individual the eighth hardest and quickest into addiction is ingesting sedative hypnotics. The drug that pushes the individual the ninth hardest and quickest into addiction is drinking alcohol. The drug that pushes the individual the 10th hardest and quickest into addiction is smoking marijuana. The drug that pushes the individual the 11th hardest and quickest into addiction is ingesting PCP. The drug that pushes the individual the 12th hardest and quickest into addiction is ingesting caffeine. The drug that pushes the individual the 13th hardest and quickest into addiction is ingesting MDMA or ecstasy. The drug that pushes the individual the 14th hardest and quickest into addiction is ingesting LSD. And the drug that pushes the individual the 15th and hardest and quickest into addiction is ingesting peyote. So those of you who are members of the Native American Church, peyote is not that addictive, neither is LSD. MDMA is not really addictive. Caffeine, not so much. PCP, not really. But then we get into marijuana, and now we're talking about some pretty heavy addiction. So there you go. That is the end of the chapter. That is the end of chapter 2. We'll tackle chapter 3 next time. That will be uppers. We'll talk about uppers next time.